Hey ladies.
Hey Casey, how are you?
Good, how are you?
Good. So we are just getting started to go over some information about the health fair breast cancer screening tomorrow.
Perfect.
So I think I'm gonna start right here. So I think there's some information we need to definitely address. First, we need to talk about guideline. So for women between age 50 to 74, we would like to have them do the breast cancer screening for every 2 years. And the benefit of that is we wanted to express this early detection and early treatment. There's a little, actually very low risk. The radiation exposure is really low. And there definitely have some limitation for the breast cancer screening, like false positive and then false negative results. So we like to have that addressed tomorrow.
And another important, couple important issues that we need to bring up is the incident rate. It is increasing in African American women. About 1 in 11 will develop breast cancer in her lifetime, and also importantly, the incidence is lower in African American women compared to Caucasian women, but the mortality rates are higher, which is a big issue. And the higher number of African American women are being diagnosed at later stages of breast cancer due to a lack of early screening and detection.
Okay.
And as far as adherence, studies have shown that adherence to repeated breast cancer screening or mammograms is particularly low among this population. One study that I found showed that among women aged 40 and older, only 23% of this target population reported getting a mammogram within the past several years, and this is really low. And this could be due to factors such as lack of physician or healthcare provider recommendations, cost of receiving screening, lack of adequate health insurance, and a lack of knowledge about the importance of early detection.
Okay.
But we should add that there have been improvements in the proportion of African American women receiving mammograms and overall breast cancer screening. In 2000, the rates for screening within the past few years actually increased to almost 70% for African American women, but they still continue to present with the greater proportions of advanced staged disease, which could mean still a lack of continued adherence to screening recommendations.
Oh, to add on that, I'm sorry. Earlier, I think I forgot to mention that the screening definitely reduced morbidity and mortality rate about 15 to 20%.
That's good.
And that's some good statistics too, Chen. But we want to realize that we want to have an evidence-based model to help us kind of gear us in where we want to go with this approach. So we have the health belief model and the perceived susceptibility. What we want to do when we are doing our health fair tomorrow, we want to provide a questionnaire to determine how much knowledge they know about the breast cancer and the screenings. Second, we want to test the severity of the level. And the way that we want to do that, we want to use maybe a witness approach to see if maybe they've had a family member that's been exposed to breast cancer that maybe have passed away, so that that can hit home, so that they can go ahead and feel as though, okay, this is something that they need to do. And also the perceived benefits of the health belief model is also imperative as well. Just basically explaining to them how often they should get a mammogram and the benefits that are entailed with getting the mammogram and things of that nature, and how they can actually prolong their life for themselves and also be there for their families in the long run. And then the barriers, we want to look at a system. So we want to look at their social economic status. We want to look at the lack of not knowing. Tools and resources are also some. And then there has been evidence that the historical discriminatory policies of healthcare institutions and legacies of the Tuskegee experiments, it continues to impact the relationship between the healthcare system and African Americans. So this is something that we want to keep in the back of our minds when we're communicating with these people. The cues of action, We probably would want to send out maybe letters to keep them in the know, like a reminder letter, when their next mammogram is due or whatever the case, just to let them know that we care and we're still connected with them from afar. And then self-efficacy, which is the ability to see how successful our approach is. Based on evidence, it shows that these women are not partaking in these services to prevent the breast cancer complication. So it'd be important to give them information on ways to stay active and continue to move forward and become more effective and improve their lifestyles. And then we have the health motivation. There are studies showing that African American women, they're not motivated because they have other priorities. They feel that it's not important for them to get screened because they're worried about their survival, how they're going to eat, how they're going to provide for their children or whatnot. But at the long run, we want to let them know that if they don't get screened, they're going to burden their family with even more stress. So let's see here. And another thing too we want to really emphasize on is getting adherence within the community. Not just with the patient, but we also want to get the providers involved as well. We want the doctors to understand the importance. So we want them to put reminders out there, letting them know maybe when they're getting their pap smear to go ahead and do that mammogram, make it like a mandated type of thing. So that would probably be an imperative factor there.
So to go along with trying to increase breast cancer screening, you talked a little bit about healthcare providers being involved. What we can do as CNLs is encourage the healthcare providers to incorporate, these screenings in their daily routine so that it becomes second nature. Also within your institution, you can suggest implementing a healthcare provider assessment and feedback intervention so that the healthcare providers are aware of their performance and, if there needs to be any improvements, they know exactly what to target. Also, I think you mentioned some of the barriers being discriminatory health policies. But in 1990, Congress passed the Breast and Cervical Cancer Mortality Prevention Act, which led to the creation of the National Breast and Cervical Cancer Early Detection Program, which provides low-income, uninsured and underserved women access to screening and diagnostic services. And since then, the program has served more than 4.3 million women and has diagnosed more than 56,000 breast cancers.
Oh, that's great. Yeah.
Then you touched upon the influence of the family and community and the religion amongst African American women, and this could be a good resource in order to help breast cancer screening amongst this population. For example, as CNLs, we can join the National Black Leadership Initiative on Cancer, which is a community outreach program that partners with a lot of academic institutions to provide educational programs to African Americans. Or we can meet with religious leaders to dispel any misconceptions they have regarding cancer and screening procedures. And then I was also reading about this intervention in Corpus Christi, Texas, where they have role models that would go on the radio or television and just share their stories regarding cancer screening and their getting treatment, so that there's a positive social reinforcement, dispersed through the media to the community. So Then another barrier you mentioned was access and transportation, right? So what we can do is provide alternative or non-medical settings for these screenings, such as a mobile mammography van at work sites.
I know it's
Or-
very hard to say.
Yeah,
I know, sorry.
Yeah.
So sorry.
Yeah,
So mobile vans, and they can go out to, you know, the workplace or residential community to provide these mammograms.
Right, so we are on the move, they don't have to.
Yes.
Yeah, that's
You're
a
reducing
really good
transportation
Yes.
and then time, you know, most of these women probably take public transportation.
Yeah.
Great.
So that's all I have to say. Is there any other additional comments?
no, I
Anything
think
else?
we have a lot of good
That's great.
information.
Yeah.
I feel like we're prepared, yeah.
Excellent, well, that's great, so let's make some change tomorrow,
Yeah,
right?
let's make
Make some changes.
a difference.
Alrighty, thank you.